Thank you very much. Before starting, please let me say it's a pleasure to hear this introduction. So it means you're a good friend. Yeah, good. So thank you for coming. It's the last talk of the meeting, so it's great to see so many people here. And I'm going to talk about baseline resistance testing, if we still need it or not. And so I'll just share with you some data and see where we get to, okay? So, well, this is my disclosures. This is what is recommended right at the moment by most of the international guidelines. Those are the updates, and if we read the guidelines, we need to do resistance testing. It's that's what I just picked up some slides from EACTS. Here you can see that EACTS recommends genotypic resistance test and subtype testing at HIV diagnosis, of course at virological failure, and if prior to starting ART, if the patient was not tested at diagnosis, then it needs to be tested for genotype resistance and subtype. This is the DHHS, and I just picked up this because here we have more information. Of course, the X has the information, but you have to go and click into those links. And here it's very interesting because we have new information. And the new information, at least for me, is that we have shifted from the typical topical of we need to do resistance in protease and the RT and maybe in the integrase, to really say when we need to do it in the integrase. And there you can read that if a person has ever used long-acting cabotegravir as PrEP, or the person has ever received an NSTI-based regimen for post-exposure prophylaxis, then you have to test for integrase at baseline, okay? So this is what the guidelines say. So let's just very quickly go through why I feel this is recommended. The first is because it has been shown to be cost effective. And this is a paper from Paul Sachs 20 years ago, 2005. Please remember the dates, because for my discussion, it's very important for you to remember the dates. So this is 2005, and there we all started to test for baseline resistance testing, because Paul Sachs clearly showed it was cost effective. The second reason, it's because it's associated to a higher probability of virological failure. And I picked up two papers. This is one from published from Linda Whitkop in Lancet Infectious Diseases, and there you can see that the people who had transmitted drug resistance were more prone to have virological failure than those that did not have them. And the second paper is for minority variants, and it's again somewhere around the same year, 2011. And this is a meta-analysis from Jonathan Lee that showed that minor variants, and especially for NNRTIs, did have also an impact in the when you choose the regimen, and it was associated with a virological failure. So cost effectiveness, association with virological failure, and of course, public health intervention. I'm not going to talk about this. We've had an excellent talk by my friend Dimitrios, and just one slide that we shared is, I just chose this slide in which Tony Fauci said really, really clearly that we needed to respond rapidly to detect and respond to growing HIV clusters to prevent new HIV infections. And this is a pillar for ending the HIV epidemic. So we've heard from Dimitrios on this. So baseline, for me, I think baseline resistance is recommended because of these three aspects. So I just pointed out the dates, and I'd like to discuss with you if there has been any changes. We have been running up to 2011. So have there been any changes from 2011 to 2025? The answer is yes. There's been a lot of changes, and especially in ART, we have had 3 excellent talks from the industry showing the pipeline. This is the pipeline up to 2020, but we have heard from Merck, from Gilead, and from ViiV what is on the pipeline. So we have been assisting constantly to improvements in drugs to treat HIV. And this is, I feel, it's really important for answering or addressing the question if we need baseline resistance testing. We have worked a lot on this, and we have been showing our data with you through papers and even in this meeting, in previous meetings. So I just want to pick up some of what we have been doing, and again look at the dates. This is March 2014. This is Spain. This is Coris, and here we posed the question if we needed to do resistance for protease, because when we looked at what we defined as clinically relevant resistance, not transmitted drug resistance, not the SDRM list from Bennett from 2009, just clinically relevant, what Jose Maria and Milos needs to start the regimen, to start a patient. If you look at that, then in the protease, we found in 2014 that this was below 1%. And I went very quickly through the Paul Sachs slide, but if we were below 1%, then it's not cost effective. So we just posed this question in this paper. This was for the PIs. The next paper and the next investigation we did in Coris, again in Spain, was for clinically relevant resistance to the integrase inhibitors. And again, just look at this. This is 2012 to 2017. And we just found hardly 1, 2, 3 patients with clinically relevant resistance to the integrase. So we again posed the question, do we need to test for integrase when we start a patient? That was what we were saying in this paper. Then we moved on to this paper published in CID. This is for the Mediterranean Europe. This is a collaboration with France, with Italy, Portugal, and Greece. And here we got to the same conclusion. It's the level of transmitted drug resistance, and more importantly, of clinically relevant resistance to the integrase is irrelevant. It's very, very, very low. And this was true for Spain. This was true for the Mediterranean Europe. And if you look at your countries, it probably is also true. And the changes have been in the guidelines. Here is what we read from the 4 major guidelines right at this moment. And there you can see that the preferred recommended, which are in light blue, are always integrase-based regimens. And we all know this. We all know that we now are starting patients mainly with integrase inhibitors. So the question is it still cost-effective? Because we are doing resistance testing because of cost effectiveness and because of public health intervention and because it is associated to virological failure. So we have been assisting to some changes. Let's see if this is still cost effective or not. Okay. So these are the data. This is the first time I read or heard something about questioning the cost effectiveness of baseline genotypic testing. This is a PhD thesis by Dineke Friends, and there in the conclusion, it's crystal clear. They say in their conclusion, in 2012, routine use of baseline genotypic testing in all newly HIV-1 infected patients is no longer cost effective. The use of routine baseline genotypic testing should therefore be reconsidered for use in certain subgroups. So this is 2012, where we started to hear that this could be not cost effective. This is from 2017, and this is a paper from Kulias. And look at the second author. The second author is Paul Sachs, and it's just the same author that put all of us to do baseline resistance testing. And here they are clearly questioning with a model. This is a mathematical model, which is really tricky and really difficult, at least for me, to understand. But they're really questioning if in the US, starting a patient with a integrase inhibitor, if there's any benefit from doing resistance testing. And if you read the paper, they even say it's worse. because it can make mistakes. It can make you guys to make a mistake when you choose your regimen. So this is 2017, and this group also has continued working on the cost effectiveness for first line, second gen INSTIs, and again, and this is 2020, they clearly show that there's no cost effectiveness to start an INSTI, a patient newly diagnosed for HIV with an INSTI first line regimen. So what do we know about other countries? Because we can always say, hey, this is the US, and perhaps it's not the same in other countries. We saw this slide, I don't know in which presentation during the meeting, but there you can see what's happening in resource-limited settings. There you can see countries all over the world, and again, the transmitted drug resistance is marginal, if it's not even present. So if you want to have a look at the cost results cost effectiveness in resource-limited settings, you can have a look at these two papers. This is Iran, and this is Kenyan woman. And again, the conclusions are clear. No cost effectiveness at this moment. So for me, at least, I think it's crystal clear that it's not cost effectiveness anymore. Is it still associated to higher risk of virological failure? That's the next question. And this is a paper from Italy published in YAC in 2018. And there you can see that if you're going to start a first line integrase based, and these patients are mostly, this is 2017, these are mostly RAL or elvitegravir patients. Some patients were on dolutegravir, but not all of them. You can see there that the conclusion is that you need to test because you need to know the resistance in the RT. And there in the Kaplan-Meier curves, if you compare the PI group to the INSTI group, you see that if you have resistance to an RTI, the patients are going to fail more frequently. This is a paper in which I participated together with Sarah Lodi and the Plateau 2 group. And here we showed that there is a marginal benefit in terms of virological failure. Look at the hazard ratio. It's 1.06, very close to 1, but it is significant. And there was no association with heart events. If you look at death or AIDS progression, there was no association. So have we assisted to any more changes? I think we have. And one of them is that we have been assisting, and even more and more, the clinicians are using test and treat strategies, because you have two combinations that have proved that you can do this safely. One is big FTAF. There are the data for big FTAF, and the other one is Dovato, and here are the data for Dovato. This means that you can safely start a patient without testing for resistance, and we have a lot of data on big FTAF and Dovato. So test and treat has clearly, it is a clear new change for considering and answering the question. And I think that the last point that I'd like to discuss with you is long-acting Cabrilpi. We have been hearing about the MVA for Cabrilpi. We know that A6 is very important, so subtyping is very important. We need to know the subtype, and perhaps the only chance to know the subtype of a patient is when you diagnose a patient, because most of the patients are going to go indetectable. And I don't know, you guys, how many of you can test intraviral DNA, but this is not available all around the world. So perhaps the only chance to know the subtype is there. And also the only chance to know if there is transmitted drug resistance for rilpivirine, which is more frequent than for the rest of the drugs. So this is another change which I think is really important. And this shows that the question we want to answer is always, and we need to think on this question as a dynamic question, because perhaps what we thought 10 years ago has changed very, very recently. Okay, so those are the data. So let's answer the question. Do we still need resistance testing? Where would you put the balance? Would you put it to yes, or would you put it to no? I think it really depends on who you're asking. Because probably if I ask Jose Maria and said, do you need this for treating, for starting a treatment in your patient? You would say no. But if I ask Dimitrios and ask him about the public health intervention, he'll say, certainly yes, we do need this, okay? So, these are the facts. We can discuss them, but I really think that baseline resistance testing is no longer cost effective with the drugs we're using at the moment, and with the pipeline, it's not going to be cost effective. TDR may no longer be associated to a higher probability of virological failure. I started this sentence without the may, but I just decided to put the may just in case someone just wanted to discuss this. Okay, so let's keep it in may. And it's really not necessary for test and treat strategies. So if you are if you rely on these three factors, you have to say no. Okay, but if you think about the importance that it provides data for public health intervention, and especially Dimitrios, if these public health interventions are on real time, this is what we really need. We really need tools that when we do the resistance baseline for a patient, we just put them in a software and says, here, this patient is associated to a rapid growing cluster. That's what I feel we need. So this is really useful for stopping the epidemic. I think it is really useful. And of course, as I showed, is maybe the only chance for a HIV subtype or for having a go and see if there are any real prevalent rounds. So if you rely on these two factors, then the answer is yes. So what is your choice? Okay, that's it. Thank you very much. Thank you.